I will give some tips and tricks for the anterior ankle arthroscopy, but I will start with, because I already dealt with the osteochondral defect, now to the anterior ankle impingement. And for me, the definition, when does a patient have anterior ankle impingement? It's recognizable tenderness on palpation on the joint line. So I don't do a dorsiflexion test. Just if the patient has pain on palpation on that area, on the medial side or on the lateral side, my diagnosis is anterior impingement. If the patient has pain, it comes with pain. Why? Because if it's recognizable pain and you palpate over the joint, what is there below your finger? It's the skin. Well, it's not the skin that gives the pain. It's a subcutaneous tissue. It is the bone, the osteophyte. Well, the osteophyte itself is not painful. So it is the capsule, it is the synovitis that gives the pain. So that's in the way. So my diagnosis is just the recognizable tenderness on palpation, and then it is anterior impingement. And then you make an X-ray to see if it's bony impingement or if it is soft tissue impingement. In this case, it will be a bony impingement. So, anterolateral impingement, anterior impingement, anteromedial impingement. Anterolateral, is it soft tissue or is it bony impingement? Anterolateral impingement, is it normally soft tissue impingement or bony impingement? Who? Both? Can be both, but typically it's soft tissue. Anterior impingement, it's bony impingement. Anteromedial, also bony impingement. Typically, anterolateral is soft tissue impingement and and is bony impingement. We published the first prospective study in 1997, and at the 2-year follow-up, you have a 90% chance of a good result if you remove the impediments. Impediments is the osteophyte and the soft tissue that's in the way, the synovitis. And the result remain over time, 5 to 8 years follow-up, 83%. And there was this systematic review from Di Giovanni and Kennedy in 2022, and indeed it shows that the average success rate is 81%, and the average time to return to sport for an anterior impingement is 8 weeks. What is interesting in our study in 1997 is that the osteophytes return in 70%, but not the complaint. So if you remove the osteophyte, and there's also this study from Walsh in 2014, the majority of patients show recurrence of osteophyte. So if you take the osteophyte and you remove it, and you make an X-ray a few years later, you see the same. It's the same osteophyte that returns. Yeah? It's important because you have to instruct your patient. You have to tell your patient. But you can also tell him that the chance that the complaints return is less than 5%. Because the pain is not from the osteophyte, the pain is from the synovitis that is squeezed between the osteophyte and the opposite side. And of course, if there's an osteophyte, there's less space, so there's more chance that it compresses. It's a soft tissue that is the pain, not the osteophyte. The development of osteophytes is an adaptive response to increase joint stability. And I showed you already this cadaver investigation. Osteophyte in an ankle is a normal thing. So don't remove asymptomatic osteophytes, because they will return anyway. I showed you already the technique for the osteophyte from the distal tibia, but it's the same for the talar osteophyte. Start in front and work towards the joint. And then you leave an area of bleeding. So if you immobilize the joint, then you will go to arthrofibrosis. So removing osteophytes in a patient where you do ligament reconstruction, if you immobilize, you have the chance that you get such a situation with arthrofibrosis. So let's say you have this situation. A patient had surgery before or a fracture, and you have this arthrofibrosis. You want to go in for an arthroscopy for an osteochondral defect. How do you do? How do you identify the joint? There's no anterior working area. Yeah, you all know this situation. You want to do the arthroscopy, you want to go to your anterior working area, there's no, because it is fibrotic. You go in, you know where is the joint space, you go in dorsiflexion, you start shaving, you stop shaving, you plantar flex, and you hope that you see something move, but you don't. You dorsiflex again, go in with your shaver, go a little bit more proximal. You shave again, towards the bone, stop, plantar flex, you still see nothing move. Dorsiflex again, go a little bit more distal. And finally you see something move, then you're in the right direction, dorsiflex, and then finally you will see the joint, and then you open the curtain to the left and to the right. That's a technique. So you go in, blind shaving, but because of the dorsiflexion you cannot damage the cartilage, and then you continue always with the opening of the shaver towards the joint, never towards the neurovascular bundle. And now you created your anterior working area. Okay, the shaver should never be directed towards the cartilage unless you want to treat the cartilage. So always angle it a little bit superior when you work on the bone in order not to damage the cartilage. On the medial side, see it as a clock, because it's not always easy to identify the talar osteophyte, because there's always synovitis, so you can miss a talar osteophyte if you don't know that it's there. And that's why this anteromedial impingement view on the right, preoperative, is very helpful, because you know there is the osteophyte also on the talar neck. So you have to remove this talar neck osteophyte as well as the osteophyte on the medial malleolus. See it as a clock. So you start with shaving at the 12 o'clock position. Oh, the video doesn't work. Is it a video? Can you see if it's a video? Yes. No, the right one? Yeah. So start at the 12 o'clock position, the shaving always towards the bone. Follow your instrument, in this case the shaver, with your scope. Always stay connected. The scope and the shavers always stay connected. You can work on the tip of the medial malleolus, go to the 5 o'clock position, go in front, take away the synovitis in front of the osteophyte. 6 o'clock position, don't shave at the 9 o'clock position, of course, because there's the joint, and you're back at the 12 o'clock position. You can also do it anti-clockwise, of course, and then you start at the 12 o'clock position, you go in front, in dorsiflexion, in front of the talar osteophyte. You have to remove first the synovitis in front of the osteophyte in order to be able to recognize it. The portals are vital, especially the anteromedial portal. If the anteromedial portal is half a centimeter too proximal, or too medial, or too lateral, you make it difficult for yourself. Anteromedial portal is easy, but it should be exactly at the correct position. Meaning, in the horizontal plane, it should be at joint level, and in the vertical plane, it should be as central as possible. Joint level, it sounds easy. First, why do you want to make it as central as possible? Because if you want to see through the anteromedial portal your ATFL, you need to have it central. Because if it's more medial, your portal, the talar neck blocks your view to the ATFL. So it has to be central, okay? Likewise, if you want to see the tip of the medial malleolus, your lateral portal should be also as central as possible. This is the reason why they should be as central as possible. Horizontal plane at joint level, the soft spot. It sounds easy, but if you have osteophytes, there's no soft spot. Yeah, you try to palpate the soft spot there, but there is no soft spot because there's the osteophyte. So how do you initially identify the joint space? You can always palpate the tip of the medial malleolus. So I advise you to palpate the tip of the medial malleolus. And this is the virtual line through the tip of the medial malleolus. And then you know that the joint line is approximately 1.5 centimeter more proximal than the tip of the medial malleolus. check with your x-ray before, but this is basically, there is the joint line. And you initially make a line with your pen on the skin. And then you try to fine-tune it by palpating the distal tibia proximal to the joint line. There you can palpate the distal tibia, and then you go down into the soft spot. You fall into the soft spot, and once you're there, you lock it by dorsiflexing. And this is then the soft spot. And then indeed, halfway your thumb is where is the joint line, and you see it corresponds nicely with my initial marking. Yeah? In this case, it is exactly at the same initial marking. So this is the joint line. Yes, those are the two ways to do it. As central as possible. How do you make it as central as possible? You have to make it in dorsiflexion because, and you see it on the video on the right, this is dorsiflexion. If you plantar flex, you will see that the anterior tibial tendon moves medial. So it forces your portal medial if you identify it in plantar flexion. You would make it here, and you should make it there. So you have to make it in dorsiflexion in order to have it as central as possible. Yeah? That's why you cannot do it. You can do it in distraction, but that means that your portal will be too medial. This is in plantar flexion, anterior tibial tendon moves your portal too far medial. So make it in dorsiflexion in order to be able to see the ATFL and treat the ATFL. The most important to not damage the superficial peroneal nerve is the nick and spread technique. You can also, of course, mark it on the skin in inversion. I always mark it proximal and distal, not at the level of the joint, because if you marked it, you cannot find it anymore. If you bring the ankle in the neutral position, the nerve moves under the skin 4 millimeters. So the nerve is medial from your marking, lateral from your marking, sorry. So you mark it like this, but the nerve moves 4 millimeters lateral if you bring it in the neutral position. So you have to make, if you want to make your portal lateral from your marking, go really more than 7 millimeters lateral. If you go more central, which I do, it's more safe. Okay? The way to hold the scope, we will do that in the lab, but I want to show you any change of instrument, bring it in dorsiflexion. So you work in plantar flexion maybe for an osteogonal defect. Now you want to change it for the shaver. Go back to the dorsiflex position to introduce your shaver. And then you do the work, okay? That's important. It's also more easy to introduce your instrument because you made your portal in dorsiflexion. So the introduction, the subcutaneous tissue doesn't move or normally moves in relation to the skin incision when you plantar flex, so you cannot enter. So introduce in dorsiflexion. This is how I now always make my lateral portal, because the lateral portal is more difficult for the soft tissue and also the nerve. So I go inside out. So what I do, I measure the distance on my trocar between the medial and lateral portal, as you see on the right. That's the distance between the two portals. Then I go in with my trocar, make sure that I'm on the bone, in the joint. I move it to the lateral side, and then I know that the tip of my trocar is exactly at the incision on the lateral side, like this. Yeah, so this is the lateral portal, level of the lateral portal, and you see my thumb is on it, and I push it through, and then I put on the scope. I can advise you to do it like this. It is more safe for the nerve also, and you are exactly with the scope in the joint at the level of the incision. Loose body removal, I showed you before. If you see a loose body, freeze. Don't move, stop the inflow, because else it is gone. And then you have to decide, how am I going to remove it? what I want to tell you is that once you have grabbed your loose body, check how you have grabbed it. Because if you grab it in the middle, it gets lost in the portal. You have to grab it at one side or the other side. So like this is perfect. I'm at the lateral side, so I can take it out without losing it in the portal. Check before you take it out how it is, how you hold the loose body. And I think that's it. Thank you so much.
Thank you very much, Dr. Van Dijk. And is there any questions from the courses? Please.
Thank you for your both presentations, great presentations. You said just palpation is enough for anterior impingement. And is it also an indication for surgery, or what is your primary indication for surgery? Time of pain, I mean, how long for pain or anything else? Thank you.
So if I understand your question well, is for anterior impingement, how long does the patient need to have complaints before the surgery?
Yeah, as you said, the palpation for the
yes.
Diagnosis.
yeah, that's an impingement.
Yeah.
And is it also an indication for surgery or not for you?
Yes. Okay, I understand the question now. Yeah, so you have a patient that comes to you. He says, I have pain already 3 months. And it is when I play sport. You ask which position you have mostly pain, and he says yes, in the front, and it is when I go up the stairs, for example. So he has the pain in the front of the joint. You investigate. You have recognizable tenderness on palpation. Your diagnosis is anterior impingement, and then you say, well, it's only 3 months. Probably I will treat conservative until the patient has 6 months of complaints. But the diagnosis is a patient who comes to you with pain in the ankle. It's superficial pain. He says, yeah, it is. The most important question for me on the pain is it deep ankle pain or is it superficial pain? Deep ankle pain means it's osteochondral defect pain or arthritic pain or subtalar pain. So then depending on the age of the patient, it's osteochondral defect or it is arthrosis, deep ankle pain. When the patient says it is superficial pain, it's in the front, then my working hypothesis is already it's impingement. And then I investigate recognizable tenderness on palpation, diagnosis is done. If I ask him to dorsiflex, is that painful? And he says no, then I'm in trouble. Because then I have a false negative dorsiflexion test. Because it doesn't necessarily, at that moment in time, need to impinge the soft tissue. Yeah? So it's false negative. I don't like false negative tests. If it's positive, nice. Then it adds to the diagnosis. But if it's negative, what then? You have a patient, he has pain, superficial, anterior, recognizable tenderness, the test is negative. You make an X-ray, there's osteophytes. You say, well, it's not impingement because your dorsiflexion test is negative. I don't like false negative tests, so I don't do the dorsiflexion test. See what I mean?
One more question.
Yeah, and then if he has an osteophyte and he has this recognizable tenderness and he comes to you, yeah, then if you treat him arthroscopically, you have a good result. So the threshold to do it is quite low for me. But I never see patients that only have 3 months of pain that come to me with this. They usually have long-standing pain, and then I don't do any conservative treatments. You might do PRP, yeah? Because of the synovitis. The PRP is good for taking away the inflammation, yeah? So you might do PRP. I don't like corticosteroids, but if the patient is older, maybe one time shot. I don't know. Probably better PRP. If that doesn't help, put him on the list.
Yeah, please.
Thank you very much, Dr. Bilgin. The question might be strange, but the topic treatment method could be applicable for OCT lesions. If not, why?
The topic?
The topic treatment method.
The topic treated method.
For-
Well, Professor Kerkhoffs has a talk on it, so I think he will answer the question, if that's okay with you. I mean, you can ask me the question later.
Okay, thank you, thank you.
But maybe,
Are there any questions?
but I think that Professor Kerkhoff will mainly do it for secondary procedures. Mainly for secondary procedures, not for primary procedures.
I'm gonna ask one
If
question.
that's already a start of an answer.
Yeah, Dr. Fan. And during my surgeries, I also see recurrence after the removal of the osteophyte. And you said you have shown the literature says nearly 84% of the recurrence, and it's most of the time it's about the synovium there. So is it true that we can define any kind of impingements on the anterior side of the ankle as soft tissue impingement? It can be similar like that, maybe the plantar fasciitis and the calcaneal spur. So maybe we can say all anterior impingements are actually soft tissue impingements, some kind of.
Yeah. Yes. All anterior impingement are soft tissue impingement. It's a soft tissue that causes the pain, and not the bone, not the osteophyte. Having said that, so you could say, okay, I have a patient, has anterior impingement, there's osteophyte. It's not the osteophyte that causes the pain, it's the soft tissue. So we just do the soft tissue. We just take away the synovitis, okay? Like you do on the lateral side, because on the lateral side it is soft tissue impingement. The problem is that postoperatively you get scar tissue, it bleeds, and then the distance between the osteophyte and the talus stays limited. So if you dorsiflex, the chance that you get a new impingement of the soft tissue is quite high. Mm-hmm. So you better remove the osteophyte, you have more space, and then the patient will not develop in the early phase a new impingement. The soft tissue will shrink, will go less and less and less, and the osteophyte comes up, but that takes quite some time. And then the chance that you get another impingement of the soft tissue, like I said, like in my experience, is less than 5%. Less of 5% of these patients I see back 7 years, 8 years, 10 years with a renewal. Do you know? What is your experience?
Maybe it's an interesting thought, actually, when you think of it. Also, I think, if you would look at the very short-term results, if you would only take away the synovitis, you would probably have like a few months of a window. Very short where you have a very good result, and then after 4 or 5, maybe 6 months, you will have the same complaints again, if you're lucky, because you can do a very quick procedure. I've never done it like that, to be honest, but considering your question, that would be an interesting approach if you would go for, okay, there's a clear synovitis, injection didn't work, and you have like 1 month until the World Cup. It might be an idea, because if you take away the osteophytes, we know that it takes a little bit longer, to do the first phase. So I think it's an interesting question for an alternative, but I agree with you. And normally I also take away the osteophytes because you want to have a result that lasts a little bit longer.
Yeah, and for that reason, the question was, what do you do conservatively? And if you are able conservatively to do the shrinkage of the soft tissue, like with the PRP, so that's for me one of the few indications for PRP. It will not, because some of those patients come that they have limited dorsiflexion. Yeah, especially the athletes, they have limited dorsiflexion. So that's another item. If they have limited dorsiflexion, of course you have to take away also the osteophytes because they limit the dorsiflexion. So if that's their question, not only the pain but also the limitation of dorsiflexion, then of course you are not going to start with PRP. You will just straight away go with doing it. Then you have also those patients post-traumatic after supination trauma or after fracture who have the anterior impingement with limited range of motion. Those post-traumatic patients, if you only take away the osteophytes in the front, the range of motion does not increase, maybe a little bit, but you also have to go to the back to do a release arthroscopically of the posterior capsule. So those post-traumatic cases, post-fracture, post-supination trauma, post-lateral ligament rupture, if they have limitation of motion, and that's their problem, then I do combined anterior and posterior arthroscopy. Release posterior, taking away the impediments in the front. A very rewarding procedure.
Is it your routine for post-traumatic cases, both the anterior and the posterior at the same time?
In fact, yes.
Yeah.
Yeah, in fact, I very low threshold to also go posterior. Because you've taken away, I mean, the patient has capsulitis at the back, of course, after a fracture, or, I mean, there's also the rupture of the posterior capsule.
Yeah,
So the
bleeding and
limitation
scar
is
formation there.
a scar, so you have the scar at the back, and the osteophytes or the impediments in the front. So only taking away the impediment in the front doesn't help at the back. So in order to have the best result, you have to go both at the same time. It's a very rewarding procedure. Anesthesiologist doesn't like it so much because you have to turn the patient during the anesthesia, so you need a lot of man and woman power to do it, but yeah, you have to convince them that it's really important and that it's not an issue.
Yeah, I want to ask a question just for me. You have an extraordinary career and you witnessed so many things about the ankle arthroscopy. We all know that there was an article in 1939, Berman published that ankle was not a suitable joint for arthroscopy. Now, we learned so many things. We use anterior ankle arthroscopy, we use posterior ankle arthroscopy for cartilage problems, for impingements, for other problems. We use for it arthrodesis, for fracture treatment, many things. Now, I want to ask for the young surgeons and for us. Now, where are we? Are we nearby the end of the road, or there are there so many things you or the other guys describe for ankle? Many new indications.
Yeah, that's a very good question. And the way I look at it is that I'm not dogmatic that I have to treat everything by arthroscopy. So I look at the patient, I see what is the diagnosis, and then I decide what is better in my hands for this patient. Can I do it arthroscopically better, faster, with the same result, or can I better do it open? So for example, the lift drill fill fix, which I showed, I do it open. I can do it arthroscopic, but I cannot do the same quality of repair as I do with open surgery. So then I prefer to do it open. So I don't think that, I think it's good that there's pioneers like Gino and myself who have been pioneering with experimenting, and we publish on those. But I also always feel the responsibility as a teacher in a conference to not just say, look at what I can do, if I don't believe that you can do it. Because what is the matter then of presenting it? So I think it's important that there is cartilage research, for example, and that there is scaffolds being produced, and that. But what I see is that then everybody's going to use it. Because at conferences you hear, yeah, you have to do a scaffold. No, I think it's good that some people, some surgeons do it to get knowledge and to tell us about it. But I think it's some of those procedures they have to develop over time and show their magnitude. The latest is always the greatest. So it's always that everything that is new is probably always better than what there was there before. Because why should it be introduced if it would not be better than, or have the promise to be better than what was there before? And so we and you as surgeons, you always are challenged if there's something new introduced, shall I go or shall I not go? Because you cannot wait for randomized clinical trials and for meta-analysis, because then you're 10 years further. And if your neighbor is already going to do these procedures, then you lose patients. So it's a difficult, we are in a difficult profession in that sense, because there's a lot of new developments. Back to your question, where will it end? There will be new procedures arthroscopically. But for example, triple arthrodesis arthroscopically, I don't know, you've been doing it. I've been doing it, but I didn't see, maybe you do, but I didn't see the advantage. It took longer and I didn't see the advantage. So I went back to open, for example. But I presented at the conference and then maybe others are going to do it. And that's dangerous then because, yeah, see what I mean?
Yeah, yeah. I will try for triple.
Yeah, so if you so if you
Okay.
see Dr. Louis from Hong Kong, he puts a scope in everything, but there's no science behind it. I mean, he just does it and publishes it, and you think, oh wow, I can do it. I can do the FHL under the foot sole, but then I say, well, what's the indication?
If I gently ask just one single advice for young orthopedic surgeons, what will it be?
My advice is to listen to the patient. The patient is always right. So don't treat the MRI. We lost the battle from the knee surgeons. The knee surgeons treat the MRI. A patient comes with the MRI, there's a meniscal tear, there's a cartilage there. Okay, and I want to be treated. And we have lost the ability for physical examination and history taking. And my take is the ankle is the most important and most important, yes, also most important. It's very interesting because you need your skills to do the history taking, to do your physical examination. That makes the diagnosis and not the CT scan or the MRI. I treat a lot of athletes, they all have, if you make a CT or an MRI, there's always something that you will find. But we're not going to treat it, are we? So listen to the patient is always right. He will tell you the diagnosis. I think that is, go back to the basis.
Yeah. Thank you very much.
You're welcome.
Thank you.